Great. So in our classwork this week, here we go. We're just finishing gynae pathology here. So we'll open gynae pathology and we're doing ovary. And I'm away next week at a conference. So I have put together the GTD virtual module to do during the week that I am not here. But let's have a think about these. So ovary, these are the key things that you need to learn. Yeah. And ovary pre-work, how is the pre-work? I'm just going to go to the chat. Was the pre-work worth doing? Tell me. All right. Yeah. So enjoyed the lecture? Great. Keep that one for next time. Excellent. All right. Thank you. And Kurt's notes are really good. We always love Kurt. God bless Kurt. Okay. Right. Ovary teaching slides. So the first one we're going to think about here is the normal ovary. And it's coming up here. I might go to full screen here like this, just to make it a bit bigger. All right, so this is a normal ovary. And the first thing I look at this, and I think it's probably like postmenopausal or close to it. We've got the fibrous cortex and then this kind of stripe of darker cortex. We've got some very bland looking cysts, and we've got these funny papillary projections on the surface here. Notice that there's lots of vessels in the middle here in the hilum of the ovary. And let's have a look at some of the structures. And we're just going to wait for it to tile for a moment. All right. So who can tell me in the chat, which I've now got to find, what this inner layer of cells is? Here, this one here. What are these cells? Where is the chat? Here it is. Here's the chat. 4 people in the chat. They are the granulosa cells. Well done. And that means the ones on the outside here are the apical cells. And look at that mitosis there. They are growing. That's okay to find one. Okay, and then over here we've got the very typical hilum, and we're going to come round and around and notice some things like the large vessels. But I'm just looking here and there's nothing going on. And I know this is near postmenopausal because the number of these little these primordial follicles is very low. So this is a postmenopausal ovary with very low numbers of primordial follicles, but still able to produce the occasional cyst. So here we go again, another follicular cyst. And the slow transition. So who can remember what the granulosa cells are called when they surround the developing ovum? What are they called when they surround the developing ovum? Follicle. Are they called? What's a cloud cells then? What's a cloud cells? Someone can tell me. What's a cloud cell? Yeah, something like that. Cumulus cell, the cloud cells. That I just like that because of its name. Here we have a bit of an old involuting corpus luteum. So we've just got these cells left. What do you think these cells are? They've got foamy cytoplasm with lots of little vesicles in them. They aren't macrophages. No clue. So these cells are still producing, these are like steroid cells. They're luteinized thecal cells at the um, end of the corpus luteum. And then we've got just here a corpus albicans. Okay, now these little things on the surface of the ovary are completely normal, right? So this is an unusually large amount of them, which is why I chose this slide actually. But here on the outside of them, what cells are these? What cells cover the ovaries? Look at that, like, Yeah, mesothelia. Well done, Shweta. So, so, oh, Adam, germinal epithelium. Would you like to unmute and tell me, is this something I don't know?
I think it's just a term I read. It's the same thing as mesothelium, just when it covers the ovary.
It's called the germinal epithelium. Very good. All right. Notice the little peg shaped, right? And they're all kind of separate to each other. This is very typical of mesothelial cells. And it's one way that you can tell them from epithelial cells, which aren't quite so hobnaily normally. Right. Normal ovary. Great. Let's go to the next bit. So, all right. So we're going to look at this one here now from the eCase library. All right, so here's an ovary and there's something wrong with it. And it looks like the middle is filled with keratin. So everyone is going easy, easy, benign cystic teratoma. Or at least I hope you are. But I'm going to tell you some tricks with benign cystic teratoma. So there are two kinds of cancers that you get in benign cystic teratoma. There's the mature squamous cell carcinoma arising from the squamous material. You very, very like let's not even mention it in the textbook, get adenocarcinoma, but more commonly is you get carcinoid tumors associated often with thyroid tissue. So top tip number one is when you're gazing at your lovely, lovely ovary here, okay, which has got nice squamous epithelium, and you notice something funny going on, something funny and vaguely glandular. The top thought is, could this be a carcinoid tumor? Okay, so we've got a couple of patterns here where we've got this nice solid islet pattern. Yep, and this, I don't think this is thyroid. I think this is more carcinoid tumor. It's got the nice granules, even though it's got the like pink stuff in the lumen there. So it's got an acinar, an islet pattern of carcinoid tumor. So every time I see thyroid tissue, which is often quite easy to spot, I go and look for the carcinoid tumor. So why am I calling this carcinoid tumor and not NET, neuroendocrine tumor? Well, A, because I first forgot. But secondly, did you know that these never ever metastasize? So these are entirely confined to the ovary. And if you see one, if you see carcinoid and it's not associated with squamous epithelium, then the thing to do is think, could it be a metastasis from the GI tract? Because we know how much they love to go to the ovary. Okay, but that's the two things that you must watch out for. Carcinoid tumors often associated with thyroid tissue and and mature derived cancers. There is, of course, the immature teratomas, but I'll cover those when you have got a bit further through the course. Nice corpus luteum through, so corpora albicantes through here, and that's that one done. All right, chat. Any questions so far? Am I going too fast? Doing all right? Yeah, not bored yet. Good. Let's carry on. Okay, so let's go here. All right, so this is a pretty typical surgical resection specimen. They send you the wall of a cyst from the ovary. And the first thing that we notice is it is quite complicated. So this is going to be most likely a borderline tumor. Um, so first I look at the architecture because that'll help me tell whether it's invasive or not invasive. And then I try to work out what cells are lining it. Okay. So we know that the common cell types are serous, mucinous, endometrioid, and clear cell. All right. What kind of cells are these, team? What do these look like? All right. So you're thinking endometrioid cells. Good thought, because I spent quite a lot of time on the uterus telling you that endometrioid cells are quite tall and thin. So this one was this one was meant to be mucinous borderline tumor. Okay. And I'm beginning to think that I put the right one in. Anyway, so it's quite important to have a good look around, okay? Because I was looking at those and thinking that they were pretty mucin poor, okay? And I'm glad that you made that mistake of endometrioid because mucin poor endometrial cells and, sorry, mucin poor mucinous cells and endometrioid cells look very, very much the same. Okay, so this extends to adenocarcinomas as well, where if you're getting a poor mucinous tumor, it can look endometrioid, and hence we do an immunohistochemical panel. So these look endometrioid, but if we go up here, all right, around here, this makes it easier, doesn't it? These are goblet cells. So, Diane, you're going to say, but you can get mucinous metaplasia in endometrioid carcinomas. And I say, yes, yes, you can, but they don't have goblet cells in them. So, the key to diagnosing a mucinous tumor of the ovary is to find those goblet cells. All right, now let's just move things around. So, we think this is borderline rather than carcinoma. So we think it's that because there's no invasion. Yeah. But often people say, are there any adverse prognostic features in these borderline tumors? And the most prominent adverse prognostic feature is that that it forms carcinoma in situ within the lumen the um, of the tumor. Okay, so most of these, you would look at those nuclei and say, yeah, those are kind of adenoma grade if you were looking at the bowel. You know, if you had an adenoma with this in it, you would be fine. But carcinoma in situ here in these ovaries, the nuclei kind of that they get up to grade 3. So the first adverse prognostic feature is um, that there is grade 3 nuclei, and there's no grade 3 nuclei here. So we've got a mucinous borderline tumor with no invasion. All right. Sometimes we can get focal proliferation within mucinous cystadenomas because it's all continuity down that RAS pathway from benign through borderline to malignant. So how much atypia do you need to make it cancer? Sorry, to make it borderline. And the answer is more than 10% or very severe. Interestingly, there's a new WHO classification coming out soon of ovary, which I think reclassifies microinvasion. But at the moment, if it's microinvasive, it's got to be less than 10 square millimeters and less than 5 millimeters in one direction. So when they become microinvasive, often they become little eosinophilic clusters that go down. And that's what I look for as I scoot along. And as well, I'm looking for carcinoma in situ with back on back glands and mega atypia because that is also a prognostic feature. But the most important prognostic feature, as anywhere, is the stage. So when we're reporting these, we look very carefully at the surface. And it's really important when you're grossing that you note whether or not the surface is smooth or ruptured. Now, we know these mucinous tumors can get quite big, so they are often ruptured deliberately. Okay, so they're brought to the surface and the mucin is sucked out of them. So you'll receive a collapsed cyst, and you can't tell whether or not it ruptured in the patient, whether it ruptured intraoperatively, and whether the mucin was just taken out. So the op note will help with that to get accurate staging. Okay. That was a bit of a talk about mucinous borderline tumors. Any other questions about mucinous borderline tumors? And tell me if I've contradicted that nice video as well.
When they talk about tumors having a component that needs to be more than 10% of the volume of the epithelial component. Are we just sort of going around the cyst and looking for 10% of the circle, or what do they really mean by volume of
Yeah, I think
epithelium?
it's you have picked up that really poor definition, right? Because we only sample the bits that look unusual, don't we? The solidy bits and the frilly bits and things. So, and we all know mucinous tumors can be like 20 kilos and enormous and horrible. So even if we do sample them according to the guidelines of one per every 2 centimeters, there's a lot that's not sampled in there. The the only advice is to go with your gut. Okay. And I would say in 10% of the sampled material, if it's more than um if it's more than 10% looks borderline in the sample material, call it borderline, because I think that is how the criteria was developed. And I think that when they developed it, they were still using the same practice as we do now, which is sample the dodgy looking stuff. But that's what I think. This is me being Diane, the pragmatic pathologist. Okay, let's go to the next one. All right, serous borderline. No, what's it doing? Well, never. Oh, okay, it's logged me out. Excuse me, it's logged me out of Path Presenter. All right, log in. All right, here we go. All right. So serous borderline tumors. So serous borderline tumors probably derive, so they are different to high-grade serous carcinomas. They're on a completely different pathway. These two are on the KRAS pathway, the MAPK pathway, and they likely derive from little cysts that start becoming all papillary and gaining more mutations. This is unlike high-grade serous carcinomas, which are essentially an unstable p53 entity and arise from sticks in the fallopian tube. Okay, so the serous borderline tumor is intermediate in the pathway between serous cystadenoma and low-grade serous carcinoma. Okay, so low-grade serous carcinoma, you actually don't need to know about in your first year. I reckon it's a second year problem. So we aren't going to cover that today, but we are going to think about serous borderline tumors, which are much more common. So serous borderline tumors classically have this, what's called arborizing branching. Okay, you can see that there's like stems, and then the villi get smaller and smaller. This is normal for these tumors. Okay. And so when we look at these serous borderline tumors, we want to identify poor prognostic features. Well, first we want to identify them as serous. So let's have a look. So serous tumors classically have little bits breaking off. Okay, they form these little broken off rosettes. And when we look at them, the cells are smaller and squarer than their mucinous or endometrioid counterparts, and they have cilia. And every now and again, um, they should have a pale intercalated cell. Okay. So this hobnail breaking off, small and square, cilia is serous. So what are the bad prognostic factors? Well, I've mentioned this arborizing branching. There's a type of branching that is called Medusa head, and I'm going to demonstrate my beautiful Medusa head here. Okay, it's like a big round ball with long, long chains of uh, thin, thin strips of epithelium coming off. So imagine it's like this, but they're about 20 cells long, like forming large villi into the space here. So this is what some people call intraepithelial carcinoma, and other people call unsupported papillary proliferation. But tumors with that pattern have a much higher incidence of spreading outside the ovary. Okay, so here we go. So I've just given you another big tip for these serous borderline tumors. Serous borderline tumors can spread outside the ovary, and they're staged just like an invasive carcinoma. We can see some bits over here, but I reckon they're carry because this looks like the outside of the ovary and is smooth. And to actually determine whether they're on the outside, we have to see them attached. So when it spreads around the abdomen in serous borderline tumor, we call these implants. We can't call them metastases because it's not actually cancer. It's a precancer, so we call them implants. If at any time in true invasion does develop, in these, it invades as low-grade serous carcinoma, and sometimes it can invade from the implants, and sometimes it can invade here in the low-grade serous ovary. Okay, so bad prognostic features are the medusa head or intraepithelial carcinoma, focal invasion, and invasive implants, which are really and are now called low-grade serous carcinoma because they have progressed. Although they're called serous, when you open them up, they will have quite a lot of loose mucin in them. All right, questions. This is one of the more common tumors I see. Questions? We all good with the pathogenesis? Yep. I'm going to have to ask you some more questions to keep you awake. Good. Everyone's happy with those ones. All right. So this is the most common tumor that I see, the high-grade serous carcinoma. And we know that this is bad because this is clearly small bowel here. All right. High-grade serous carcinomas most often present at stage 3. In other words, they have spread around the abdomen. And most often, well, I get two kinds of specimens. I get the specimen that's the diagnostic biopsy before they start chemotherapy. And then I get a specimen after 3 cycles of chemotherapy, which is the interval debulking specimen. This is an interval debulking specimen. So high-grade serous carcinomas, as I've mentioned, are all have a p53 mutation, which means they're very genetically unstable. And like the ones in the uterus, they appear like wild looking, really pleomorphic. Now we're doing more molecular. There's a little trick I want you to know. We used to be able to diagnose, well, we still can diagnose serous carcinoma on any old little bit of tissue. But the question that clinicians can ask is something like, and is there enough to do BRCA and PD-L1 testing? Okay, because about 70% of these carry a BRCA mutation, and everyone is now BRCA tested on the tumor for it, and also somatic BRCA tested. And you need about, to do all the molecular tests now, you need about just under a cubic centimeter, half a cubic centimeter, say the tip of half of my little finger here to do it. So if they ask you, do they have enough for molecular, they need like 318 cores or one chunky 16 core with cancer in it in order to get enough. But let's have a look at this tumor. There are 2 main patterns for this tumor, and this is the first one. This is the micropapillary pattern. So what we mean by micropapillary? Well, what we mean is that this is a bit like a flipped inside out sock. So if you think of a sock and that's an acinus, and then you put your fist in it and put like it's like intercepting up, yeah, it flips everything inside out. So now we've got a vessel in the center and the epithelium on the outside. And if we stain it with an epithelial stain like an EMA, that usually stains the lumen, it now stains the outside. And because this is really the lumen, it starts to secrete. Okay. And that's why they've got a gap around them. So it's like an inside out sock with the vessel in the middle and these secreting into this space here. So this is the micropapillary pattern, and this is the one that's most easy to recognize. The other one is the solid pattern, and that's where I usually have to do immuno. So these have usually spread because they're very spready, and the ovary is very deep and really doesn't get detected early just because it's so deep. Let's have a look for some other patterns because it can grow in other patterns. So, oh, these are all micropapillary. You can see the little hairs of the micropapillary coming out there. Maybe there isn't any other patterns. All right. Oh, it's maybe forming some acini around here. So I've diagnosed it. She's had three rounds of chemotherapy, and they do what they call optimal debulking. After chemotherapy, optimal debulking, and another round of chemotherapy, women's lives are significantly extended, say 5 years. But stage three is never curable. Okay, so here we go. Uh, you may or may not have encountered breasts yet with chemotherapy, and you've got to grade the response of chemotherapy, haven't you? Yep. No. Yeah. So sometimes you have to grade the response of chemotherapy here. Fortunately, it's much easier. So you will need to look it up the first time, but basically lots of tumor, hardly any response, and there are very few of those. The second one is like this, where there appears to be large areas of fibrous tissue, plus or minus macrophages, and this looks like it's had some response, so it's a 2. Yeah. And then there's the ones where you're hunting round to try and find tiny bits of tumor, and they have complete or almost complete response. So remember, impress your consultants by saying, and I have graded the response to the chemotherapy. That means you do have to look up the chemo that you have to look up to see when they've had chemotherapy. But usually by the time you get this, they have. So these arise from the fallopian tube, sticks. So when we report their biopsy, we say serous carcinoma, high-grade serous carcinoma of tubo-ovarian origin, p53 mutated. The other thing that we often do is a WT1 because WT1, a common ovary positive immuno, is positive in these, but the serous carcinomas from the uterus, which look exactly the same and are also p53 mutated, are usually negative. So top tip is to do at least a p53, a PAX8, and a WT1 when you're diagnosing these. All right, next. Okay, so I've got Brenner tumor here. Brenner tumors, here we go. Aren't they good? They, of course, derive from the um, mesonephric remnants, and they resemble transitional cells. And they're quite often found incidentally, where we can appreciate their beauty as these little nests of bland cells within the fibrous stroma. They all point towards the middle. They kind of stream towards the middle, just like transitional epithelium does. Do they have a nuclear groove like transitional epithelium? The answer is sometimes. Maybe I'll be able to convince you that one's got a nuclear groove. And then what happens next to these Brenner tumors? Well, some of them start to develop into cysts. Still a Brenner tumor, still waiting for the tiling to resolve. Okay, because they secrete mucin into the middle. And some people have suggested that metaplasia in these Brenner tumors leads to the mucinous cyst adenomas because they are associated with finding mucinous cyst adenoma. It's extremely rare to find a malignant one. All right, right. Next quiz question. What is this stuff? What's this stuff? So we've got the islands of Brenner tumor here. We've got collagen and this stuff. What's this stuff? Yeah, calcium. Because the Brenner tumor is so slow growing and has been hanging out for so long that the fibrous tissue becomes calcified. And calcification is usually a reassuring feature that things have been hanging around for a long time. Not Sonoma bodies, however. Okay, so that was just a nice straightforward one to talk about Brenner tumor, commonly seen. You just have to get used to recognizing this kind of little insular pattern, and then you feel really clever and go, oh, Brenner tumor, yes. There we go. Okay, next one. All right. How are we doing for time? I feel like I'm racing through. Uh, I am. Adrenal rest. This is another cute thing. So I quite like teaching you guys cute things and things that are things that you will encounter but not necessarily know what they are. So we've got fat, we've got ovary here, right? Do you think this ovary is premenopausal or postmenopausal? Yeah, that's right. It's postmenopausal because we can't see any of the little ova. And really, we don't have any active follicles. We've got lots of these corpora albicantes. And what's this here? Yes, a cortical inclusion cyst. So if I stained this, what would it be lined by? Do you think it would be calretinin positive, like mesothelioma, or Paxate positive, like ovarian stuff? They're mesothelial derived for sure. I actually don't know the answer to that. I'm sorry, but I have just gonna look that up. All right, who can look it up faster than me? This is now a challenge. Um, we're gonna try and work out what they're staying like. There are two types. Peritoneal inclusion cyst, flat epithelium, WT1, D42 positive, Paxate and EP2 negative, and then the Mullerian inclusion cyst. All right, lined by ciliated tubal epithelium as the result of implantation. So these are the ones that will give rise to the serous cystadenomas. Um, and these ones will just sit there and look inactive. Right, if it's less than 1 centimeter and it's a Mullerian inclusion cyst with the cilia, then we just call it a Mullerian inclusion cyst. If it is more than 1 centimeter, we call it a cystadenoma or a cystadenofibroma if it is complicated. So that is the 1 centimeter rule. Okay, so two entities that are really the same, have the same name. All right, back to this one. Okay. Um, so the thing I'm really going to show you here is this thing, which is the adrenal rest, which can look a bit alarming the first time you see it. But we're going to have a look around at all the other soft tissue ditzels that we find as well. Remember when I said that that something was a steroid cell earlier because it had like a nucleus and then all these little tiny vesicles and the nucleus is kind of indented. Yeah, it was in an old corpus luteum. So these are the typical steroid cells of the cortex of the adrenal. Now we aren't going to get um, any cells here from the sympathetic chain because it is separated from it. But who can tell me what the brown stuff is? And what is the brown stuff? Okay, it is lipofucsin. And where's it from? What causes it? I'll tell you a story once you've told me what causes it. Yeah, it's the breakdown of stuff. So it's rubbish inside the cell, isn't it? It's the stuff that the ubiquitin can't chuck out of the cell, right? So my story is some people have hepatitis and before they have hepatitis, they have a liver full of this lipofucsin. But after they've had hepatitis, where most of the liver cells have died and they regenerate, it all goes away because they have new cells. So it tells you that these cells have been sitting around here being a bit inactive for a long time, as expected. Right, down here we've got some other little things. What are these? What are these things in the adjacency of the ovary? Yeah, they are duct remnants, and that was very good dodge, Adam, because of they mesothelial or Mullerian duct remnants. Not mesothelial, mesonephric, sorry, mesonephric. Yeah, mesonephric, well done. These are mesonephric remnants. Okay, we know they're mesonephric remnants. They're like little vas deferens. They think you vas deferens. It's got smooth muscle around the outside, and they're a bit ciliated. If you go next time you get a vas deferens, have a real good look at it and see if it's ciliated. So these are the mesonephric remnants. Well done. And then over here we have this Mullerian organ, the fallopian tube. So this one is looking a bit tired and worn out because she is postmenopausal. So just like everything else in the postmenopausal female genital tract, the fallopian tubes involute a bit. All right, let's have a look. Okay, there are three kinds of cells here. Who wants to tell me what the three kinds of cells are in the fallopian tube? Yes, ciliated, non-ciliated, and PEG cells. Yes, and the PEG cells are what I call the intercalated cells. And the non-ciliated cells are the ones that I often call the secretory cells. So they've got a couple of other names. Um, and here we go. These are the intercalated cells, these pale ones. And the ones with the villi, here we go, these pinky ones, they're the ciliated cells. And the bluer ones, they're the secretory or the non-ciliated cells. So we cruise around fallopian tubes looking for sticks, and we recognize them by their hyperchromasia. But the most common cause of hyperchromasia in the fallopian tube is hyperplastic secretory cells. Okay, hyperplastic non-ciliated cells. And so we look at them when they're forming blue things and go, are they atypical? And they aren't. So, I mean, these fallopian tube cells, they're pretty crowded, they're overlapping, they have little nucleoli, and that's completely normal. When they look atypical, they look like the wild things. They look like the serous carcinoma. What do you think this might be? There's two things it might be, and I can't tell which one it is. Yeah, calc or yeah, it's yeah, it does have a kind of radial. So I was thinking a wee radial calc. I was wondering if it might have been actinomyces, just a tiny bit of it, but maybe not. I do prefer it for a calc. All right, so that's the fallopian tube. There's another one over here, another little calc. So calcifications in older women in the fallopian tube. are expected. And this is like an infolding. Yep, those weird cells there. Often that's the thing as a first year, it holds you up, is I've seen a million weird cells and you have not, and you wonder whether those weird cells are significant. But we can kind of follow it up to here and it comes around. But sometimes I worry about the weird cells and do some stains on them. What stain would I do if I was worried here? One stain to rule them all. P53, yes, I would do the P53. Yeah, and that would tell me whether this was um, a stick or worried at all. All right, that was the adrenal rest. So the four types of carcinoma in the ovary are mucinous, serous, clear cell, and endometrioid. And we talked quite a lot about endometrioid the other day in the in the endometrium. It arises from endometriosis. But this is clear cell carcinoma. So we can see here, this is a small clear cell carcinoma confined to the ovary, stages everything. Okay. And you're going to look at this and say, hey, Diane, those cells are not particularly clear. Some of them are clear. Both serous and endometrioid can have some clear cells in them. But the thing that characterizes the clear cell carcinoma is that it has got really well-defined cell borders. It's filled with glycogen, and the nuclei are often central and craggy. And so the morphology is quite important. Look at the way, too, it has hobnail cells. All right, the cells form these little papillae and are hobnails. So now you're going to say, but Diane, serous carcinomas can look like this. And I go, aha, you're right. They can look like that. Um, the hobnails here in clear cells, when you've seen a lot of them, you will see that they are larger. The cells are larger than the hobnails in serous. And it's always important to look quite carefully if you're trying to tell the difference between this micropapillary pattern for the little patches of clear cells. So usually in clear cell, you have more acinar than you have papillary. And even though it's papillary, they're kind of arranged in little acinar groups. But sometimes in clear cell, the cells aren't clear, but they're pretty much always square and hobnaily. So they have a look to them. But very fortunately, they also have an immunohistochemical profiled to them. All right. So if I was going to tell this from a serous carcinoma, I would do a P53. I would do an ER. I would do a napsin A. I would do a WT1. Okay, those are the most important things to do. The napsin A could be replaced by another one that begins with H that I've forgotten the name of, HBM something, but we could never get it to work in our lab, so we stuck with the napsin A. The napsin A, yeah, thank you, HNFB1. Thank you, Janetta. You probably have more immunos than Waikato. But the napsin A doesn't stain every cell. It stains cells patchily and it stains in the cytoplasm. Nuclear stains are always much easier to read, but it is reliably positive in these. Whereas the WT1 is always negative. The P53 is usually negative. The ER is always negative. And serous, the ER is usually present or weak. Sometimes it's negative, but it usually get a bit of staining. P53 positive, WT1 positive, and napsin 8 negative. Okay, So clear cell carcinoma of the ovary, characteristic appearance, some pitfalls in that it can grow in a papillary fashion and that it's not the only clear cell thing on the block. And sometimes it's not even clear cell. Let's look around. Just waiting for this to sort itself out. Okay. Here at the hilum of the ovary, we've got these little chaps. What are these cells? They're cells with copious eosinophilic cytoplasm around nucleus and prominent nucleolus. What are these? Do you need a clue? They're associated with something that might be a mesonephric remnant. Look, some more mesonephric remnants around here with the smooth muscle. Yeah, Leydig cells. These are our friends, the Leydig cells, more commonly seen in the testis, but there are always hilar Leydig cells in the ovary. And here's a big clump of them here. So if you see ones that look like this, these are Leydig cells. I have never seen a rinky crystal in them, even though the textbooks say they're there. I've never, ever seen one. Okay, so what else is on this slide? We have a fallopian tube that is also looking slightly postmenopausal. So I usually scroll through these at 4 times, and then I see the purple bits. And here we have some cross-cutting, but we also probably have some secretory hyperplasia. Okay, but that looks pretty normal otherwise. Okay, that was clear cell carcinoma of the ovary. Let's carry on. Endometriosis. All right, how many times a day do you guys see endometriosis? How many times a week do you guys see endometriosis? We'll do it week because not everyone is buried in gynae. Yeah, it's really common, isn't it? So for me, a gynae pathologist, I'd say it 3 times a day at least. It's really common. And sometimes it's quite subtle. This is not subtle. So to diagnose endometriosis, you need it's the 2 out of 3 rule. Okay. You need endometrial type epithelium, endometrial type stroma, and blood, 2 out of 3. Look here, these have got cilia on them. Well, that's weird because they're endometrial cells. What cells in the endometrium have cilia? Yeah, the surface epithelial cells. Well done. Yeah. So it's okay to find cilia in endometriosis. So here we go. We've got loads of scarring here and it's been cut out. So this will probably, it's in the abdominal wall. So this is most likely to have come from somewhere like a scar from a hysterectomy. Um, it's causing lots of chronic inflammation and fibrosis. And this is its problem. It causes lots of chronic inflammation and fibrosis everywhere it goes. And then the clinicians come in and take bits out and send them to us. I honestly think, you know how we have specimens that we think we don't need sending to us? I honestly think I don't need all the endometriosis. I think they're pretty good at identifying it by eye, but I also think that they somehow need it like a histologic diagnosis to get access to payment or medicines or something. Anyway, endometriosis. Okay, so here we go. That brings us to our little zoom through, which means it's time for the ovary test cases. Any questions before we carry on? I'm going to stop recording.